Good evening, good evening, good evening to those who are here. Thank you so much for joining us for our first session of year 3 of Spotlight Endometriosis. For those we haven't seen since last year, Happy New Year, Happy 2023. And we have such a great session for you guys this evening and for the rest of the year. And I want to apologize first for being late, some technical difficulties. So you know how the thing goes sometimes. But we're here and we're about to start. So welcome again to all. And I want to say special welcome to our guest for the evening, Heather Guidone, from Atlanta, Georgia. Yes, of course, she said she's in New York now, but you know, home base is Atlanta. So Heather is no stranger to us. She said to refer as the crazy lady. So the crazy lady is back with us again this evening. She loves the TTEA and we are glad she's here with us, right? So to kickstart everything, because you know I like to jump right into it. Yes, I want to read our disclaimer before I read our illustrious guests' credits. So, as you know, the information shared in this event is for general informational and educational purposes only. It does not constitute professional or medical advice, diagnosis, or treatment for individuals. Please consult your healthcare professional if you have questions about your health or before starting any treatment. The views and opinions expressed in this event are those of the presenter and do not necessarily reflect or represent the views and opinions held by the TTEA, its sponsors or donors. Due to the nature of this event, it may contain content copyrighted either by another entity or person. The TTEA, and its sponsors or donors claims no copyright to said content. The TTEA is only a messenger and sharer of information and strives to verify but cannot warrant the accuracy or of copyright or completeness of the information in this program. If you have a complaint or find your content is used incorrectly, please contact the TTEA prior to making copyright claims. Any infringement was not done on purpose and will be rectified to all parties' satisfaction. Right. So I move from one device and I'm going to another device now to read Heather's. So give me less than 30 seconds. Right, so I have it here. Heather Guidone BCPA, and she goes by the acronyms he, she, her, and hers, is the program director for the Center for Endometriosis Care, or CEC, in Atlanta, Georgia, in the USA, where she's responsible for oversight of the center's comprehensive multidisciplinary care program. She coordinates the CEC's clinical research as a PI site and serves various disease education, advocacy, support, legislative, and public policy endeavors. She lectures internationally and is a contributing author to various women's health, endometriosis, and pelvic pain books, articles, and lay and clinical health education campaigns. Heather also serves on various journal and other editorial boards and volunteers for a number of nonprofit organizations in an advisory capacity. In addition, she sits on several research funding review panels, including for the Office on Women's Health, PCORI, and the U.S. Department of Defense Congressionally Directed Medical Research Program, as well as others. Additionally, she's an appointed member of the Institute for Clinical and Economic Review's Comparative Effectiveness Public Advisory Council. She has worked in the endometriosis space on countless initiatives for the past 3 decades, and personally has extensive lived experience with advanced endometriosis, which informs her professional efforts. She continues her work to ensure stakeholder and especially patient representation wherever decisions about the disease are being made. That was a mouthful. And of course, Heather totally understands what endometriosis is as a researcher in the field and as well as a patient herself. So Heather, thank you, and the floor is all yours.
Thank you, thank you, thank you. The first and most important thing I want to do and say is to thank you, the TTEA, everybody on your team, for all of the endless work that you do. You are always putting the spotlight on the disease, and we love you for it, and I'm so grateful to be here. So thank you, thank you, thank you. And thank you to everybody who is spending Saturday evening with us. You know, I said on one of my posts earlier, Saturday is for friendos, right? So I am honored to be here. It is a privilege, and I am so grateful. I am going to jump right in and start sharing my screen. I know some folks may need to step away or stand up or get a drink or a snack. Please feel free to do that. We will be here when you get back. We have a lot of ground to cover tonight. And I really want to do some deep diving into some aspects of the disease, so that we can really cover, you know, beyond the basics, right? So I'm just going to try to get this to start streaming, and hopefully everybody can see that. If not, we can always resort to interpretive dance if that doesn't work out. So tonight's topic, Riddle Wrapped in a Mystery Inside an Enigma, first coined by Dr. Wilson and expanded by Mary Lou Baldwin of the Endometriosis Association. I think it's a very apt and apropos term for this disease. Standard disclosures and disclaimers and statement of inclusivity apply. Anybody who has ever seen me lecture or knows me knows that I like to be as inclusive as possible, and I absolutely recognize that sex assigned at birth is not always consistent with gender identity. No financial relationships or affiliations with any commercial interests. I work exclusively and solely for the Center for Endometriosis Care. And of course, this is all for educational purposes only. Please do not take this as medical advice, as Ambah said. And as I said tonight, I really want to talk about endometriosis, what it is, what the impacts are, although it's not a mystery to anybody attending tonight who's living with the disease. You know the tremendous personal and public impact that it has. Talk about some interdisciplinary ways in which the disease can be treated most effectively. And importantly, to discuss the role of advocacy. And there's been a lot of chatter on social media lately, this week in particular, about the role of advocates and what we do and why the work we do is so important. I think Nikki Hudson said it best. Endometriosis is a phenomenon which has come to be defined by a lack of scientific knowledge and consensus. I think that nails this disease. You know, there are a lot of differing opinions and a lot of different conversations about what endometriosis is, who it affects, how, and why. It is not a new disease, okay? Endometriosis didn't just suddenly crop up, you know, a few years ago and become trendy. We have seen ancient mentions of endometriosis as far back as old medical scripts. However, it was first generally credited to Dr. Karl von Rokitansky in 1860. And there's a lot of debate about what is endometriosis. The official and formal definition is a disease characterized at surgery by the presence of endometrium-like epithelium and or stroma outside the endometrium and the myometrium. Now, simply put, in lay terms, that means endometrial-like tissue that's found elsewhere in the body. It is not identical to the native endometrium. It behaves differently and functions differently, and it looks different under the microscope. And we know that it behaves differently. So there's a lot of differential adhesive, invasive, and proliferative behaviors in the tissue of endometriosis versus what would be considered a normal or native endometrium. And it's been found in every organ system. It's not just confined sort of to the ovaries or, you know, in the pelvis, but we're going to talk about that. Complex, complicated, confusing, convoluted. Insert your description here, right? There's a lot that can be said about endometriosis in terms of what a complex disease it really is. Inherent characteristics that you see with endometriosis include things like distorted anatomy, fibrosis, formation of painful endometriomas, which if anybody has had them, you know they're painful, large, sizable chocolate, quote unquote, chocolate cysts, processes of repeated tissue injury and repair, organ dysfunction, lots of pain. And we're going to talk a little bit more about pain as we dive a little deeper in. And endometriosis doesn't usually come alone. There are sometimes concomitant or comorbidities, things that we see in the literature as perhaps associated with endometriosis, things like migraine, multi-site chronic pain, inflammatory conditions, comorbidities like IBS or IBD or other GI difficulties, gynecopathologies such as adenomyosis or fibroids, certain autoimmune diseases, although endometriosis itself is not an autoimmune disease, but we do see higher incidences of certain autoimmune diseases in people with endometriosis. Things you might not expect, allergies, chronic fatigue. More recently, we're seeing things like rheumatoid arthritis, coronary heart disease. There was a lot of discussion about that in the medical journals and the public discourse last summer. Even very recently, we've seen mentions of possibly multiple sclerosis, although that has not been confirmed. Infertility, obstetrical outcome, adverse obstetrical outcomes, and of course, increased use of IVF or ART, medically assisted reproductive techniques, because of the impact that it can have on fertility. About 190 million people globally are affected, predominantly, of course, women and girls, and an unknown amount of transgender and gender expansive folks. We know it's the third leading cause of gynecologic hospitalization in this country. Predominantly, you would see it or have it referenced as a gynecologic disease. However, the extrapelvic manifestations have been reported in a considerable number of cases and are probably underreported. It's been found in cis males, it's been found in fetal autopsy, and unfortunately, there's a very, very low, very slight, but still risk of possible malignant transformation in some forms of the disease. But again, I want to stress it's exceptionally low risk. Some locations where endometriosis has been found as documented in the literature. Of course, we have the abdominal pelvic region, yes, places like the rectal sigmoid colon, gallbladder, appendix, but places you might not expect. Heart, back of the knee, gluteus minimus, lumbar plexus, abdominal wall, gallbladder, diaphragm, lungs, heart, thumb, skin, eyelid. All of these places have case reports in the literature. Of course, obviously, some are, once in a lifetime. Others are going to be obviously far more common. But it just demonstrates how it's not just a pelvic disease. It's not just a bad period. And I don't need to tell anybody here who lives with this disease the drastic interpersonal toll it can take on your life. There are studies well-documented studies talking about patients reporting how those around them, including their loved ones and their doctors, that, if they have menstrual symptoms as related to endometriosis, that, they're menstrual moaners, you can't handle a period, you're seeking attention, you should be able to handle it. And that leads, of course, obviously to, painful lived experiences, senses of rejection, feeling like a burden, painful sex, impact on sex life, straining of social and intimate relationships. All of these things are very, very common with endometriosis, unfortunately. And that's often made worse by what we call gaslighting, or being limited at the doctor by being told you're just looking for attention. It's in your head. You're making it up. And because of that, the majority of patients will complain for about a decade. In more than 60% of cases, symptoms arose before the age of 20, but folks had to see up to 10 physicians over a course of 10 to 12 years before they were taken seriously. Unacceptable. Marcia Carnero wrote recently reports on those with endometriosis undergoing multiple medical evaluations and having complaints dismissed, including by gynecologists, are very common. And she goes on to say that they were told their pain was normal. And she nails the question. When is pain normal? Pain is never normal. And unfortunately, we still see that right now, today, 2023. So taking a look at our center's population, there's Dr. Cinervo. Give him a wave. Hi, Dr. Cinervo. Who has endo in our population? Now, obviously, we are not wholly representative of the global endometriosis population, but what we see in over 11,000 of our patients, they've come from 70 countries, varied race, ethnicity, cultural, religious, socioeconomic backgrounds, patients as old as 84, young as 11. The important part of this is that 65% have had a diagnosis, which means they've had at least one surgery, and they relate to us in their narrative, which is a very important piece of intake information that we gather from all of our patients. They relate that they've had at least one treatment that they perceive as a failure. 13% of our patients have undergone prior hysterectomy. Many of them are still found to have endometriosis. As you can see on the right, I apologize, I should have warned you, graphic photo. As you see on the right, that is a 16-year-old patient. You will note that the lesions are what they consider early or vesicular or clear. Many of the procedures that we do, and we'll talk about interdisciplinary operating rooms as we go in, but what our surgeons are doing most commonly are things like myomectomies alongside excision of endometriosis, repairing the rectovaginal septum, exploring the retroperitoneal space, appendectomy. We see a lot of patients with endometriosis-involved appendices. Adhesions, always a problem. So we're seeing the gamut. And Dr. Cinervo himself performs among the highest number of thoracic endometriosis cases anywhere in the world. So whether it's rare or just not seen elsewhere is up for debate. Why does it occur? We don't know. We still don't know. Eons and eons of research and debate has led to no additional comprehension of pathophysiology. Most likely, it is complex and involves many different factors, often which probably occur simultaneously. We think that, that there are multiple reasons why endometriosis occurs. There may be a common trigger. Most likely, it is probably the result of multifactorial reasons. Each form of endometriosis may actually have a different cause, which can really lend to the complexity. You will hear retrograde menstruation talked about a lot. The bottom line about retrograde menstruation is that it simply cannot explain all disease in all people. More likely, it is related to that combination of factors, dysregulated interactions between anatomy, hormonal factors, immunology, genetic and epigenetic, even environmental factors, all of these things coming together to allow for endometriosis to occur. And we talk a lot about Samson. I know that the patient population is very active, particularly on this topic. So I wanted to talk a little bit about it, to kind of clarify a few aspects. So John Sampson was a physician from Albany, New York. About 100 years ago, he came up with this theory of retrograde menstruation. It is still very widely promoted, but even he himself said it cannot account for all endometriosis and what he called endometrial-like tissue. And as we talked about earlier, it may explain ovarian as some forms of endometriosis, but it cannot explain deeply infiltrating, cannot explain lesions outside the peritoneal cavity. About 70 to 90% of people with periods will have retrograde menstruation. Not all of them will develop endometriosis, only about 10% will. And as I said, the native endometrium is different from the tissue of endometriosis itself. So the jury is still out on any single underlying cause. We know retrograde may be part of it for some people, but it is not the only answer. And that segues nicely into the fact that endometriosis is not just a painful period. And we talk about this a lot too. You'll hear online and you'll hear, in groups and organizations, it's not just killer cramps. It's not just a painful period. There is a body-wide systemic impact, a vicious cycle of pain, distress, physical inactivity, physical deconditioning as a result, and of course, depressive mood, anxiety, all of which sort of work on a loop because let's face it, it's pretty depressing to live with a chronically painful disease, right? Killer cramps, not normal. They should not be dismissed. You know, for those in whom menstrual pain is part of their endometriosis symptoms, if it's keeping you home from school, if it's keeping you out of work, if it's keeping you from sports or your life in any way, that's just simply not normal. Okay, and endometriosis plays a big part in diminishing physical, sexual, emotional, reproductive health, all of it. And you don't need a uterus to suffer from endometriosis. As I mentioned, we see patients all the time after a hysterectomy. I've already kind of touched on the non-menstruators and those without a uterus, fetal autopsy, cis men, after oophorectomy. And we'll talk a little bit more about that as well as we go on. So it's not a disease of painful periods. What does it feel like is a really sort of subjective question. What's it feel like to you is what matters. You know, not everybody with this disease is going to have all the symptoms. My symptoms may have been very different from everybody else here. No two cases are identical. And of course, responses to treatment aren't always identical as well. Staging, we know that the ASRM staging criteria is the most common used. None of the staging systems that are used right now, whether it's Enzion, ASRM, or the AAGL system, none of them really correlate to symptom burden, meaning you can have stage 4 and have less pain than someone in stage 1. So I don't like to put too much emphasis on staging per se in terms of symptoms. Typically, we see things like chronic pelvic pain, abdominal pelvic pain, as I mentioned earlier, bowel, urinary dysfunction and pain and disruption, very, very common, crippling period pain, painful intercourse, sometimes pain with tampon insertion or pain with a pelvic exam, infertility, of course. If you've got pleural or thoracic endometriosis, you may cough up blood, sciatic, lower leg and back pain. These are some of the more common ones. Clearly, this is not an exhaustive list. And it's definitely a constellation of symptoms that can really impact all life domains, as we talked about. About 72% of folks in one study had at least 8 endometriosis-related symptoms that they reported as interfering with their daily life and work. Obviously, of course, negative impacts on your physical and psychological health, your relationships, your education, your pocketbook, okay? Finances, this is an expensive disease. Daily work activities. And again, this is made worse by clinician normalizing and dismissal and trivialization. That can lead to a lot of frustration at the patient level and also, unfortunately, delay appropriate management going forward. Now, I'm not going to spend too much time deep diving into this because this could really be, you know, sort of a presentation on its own. There's a very, very complex relationship between endometriosis and pain. Nociceptive, neuropathic, and nociplastic, which really speaks to the sensory receptors and how those messages are delivered. Sometimes it's the result of an actual injury, as with endometriosis causing, quote unquote, an injury or tissue damage. Sometimes it's neuropathic, and sometimes the pain amplification is increased at multiple levels. And we see other things in the research, such as nerve fibers, pro-inflammatory stimulation, biological mechanisms of the lesions themselves. And there's been some talk about an endobrain in the literature. And what that really refers to is actual changes in the gray matter of the brain, altered brain chemistry or function in the pain processing regions, specifically in people with endometriosis who also suffered with chronic pelvic pain. And they had more severe pain, greater sexual and social dysfunction, as you would expect. The good news is proper treatment can improve this. Unfortunately, as I said earlier, we see a lot of complex chronic pain syndromes riding alongside endometriosis, things like interstitial cystitis or painful bladder syndrome, IBS, IBD, things like that, pelvic floor dysfunction. And sometimes that can really complicate things. So you always have to look for secondary pain generators and treat them as well. Now, with all of this said, not all pain is endometriosis, okay? It can be something like we talked about interstitial cystitis on its own. It may be an infection. It may be an acute situation, such as an ectopic pregnancy, pelvic floor dysfunction, ovarian remnant syndrome, which is uncommon, but we see it. Ovarian torsion, very painful, cysts other than endometriomas, functional cysts, and something along the what we call the palm coin spectrum, and that refers to uterine issues, polyps, adenomyosis, fibroids, malignancy, unfortunately, in some cases, dysfunctions, iatrogenic, which means doctor caused, that might have been an injury or something suffered in a prior surgery and otherwise not classified. So any of these can be present in addition to or instead of endometriosis. So it really speaks to the importance of arriving at a true diagnosis and not just being suspect of, and assuming that it's endometriosis. You really have to look for the diagnosis and treat what's going on with the patient. There's a lot of talk lately about clinical diagnoses, sort of just, well, we think it's endo, so let's treat it. The real actual diagnosis is histopathological, and that means surgery, taking biopsies, looking at them in pathology, and seeing what components are there. Epithelium, gland, stroma, or hemocyte-filled macrophages. You have to have at least two to be considered a diagnosis of endometriosis under the microscope. Not everybody wants surgery. Not everybody is a candidate for surgery. But in terms of non-invasive diagnostic tests, we are still lacking on those. Imaging can be helpful, but it can really not rule out endometriosis. So laparoscopy remains the gold standard. And as our founder, Dr. Albee, has said, if the diagnosis has not been surgically established, it is possible the wrong disease is being treated. And I think that that's pretty important. Unfortunately, diagnostic delays remain a major problem with endometriosis. We are still seeing, commonly massive delays in diagnosis, 10, 11, 12 years, sometimes longer. A lot of that speaks to the lack of awareness or the lack of accurate awareness among the public, employers, healthcare professionals. A lot of blaming on bad period, a lot of telling patients you can't have endo because you're too young, you're too old, you had a hysterectomy. Even with the best imaging in the best hands, we still see diagnostic delay, and it's a real problem. And then there's things like assumptions made based on anchor bias or premature closure. That means that you're taking the first bit of information presented to you about a patient, deciding that's what it is, and stopping the investigatory process at that point. And part of the big problem is that we still don't have a concrete non-invasive diagnostic. In terms of under-resourced populations, they are facing additional barriers, as if there could be, anything worse than what everybody with endometriosis goes through already, particularly adolescents. We know that about 70% of teens with pelvic pain later go on to be diagnosed with endometriosis. 60% of them will present within 6 months of their first period with symptoms, 80% within 3 years, yet they're still dismissed. And unfortunately, the delay in diagnosis leads to what is basically a chronic disease with a potential for progression and to be damaging, both in terms of pain, in terms of destructive lesions, but also in fertility, future fertility. So there's an encouragement that a strong consideration should be made for surgical diagnosis in adolescents with pelvic pain, particularly if they have a family history. We know that those with mothers or sisters, first-degree relatives, who have endometriosis are at about a 7 times increased risk of having the disease themselves. So we really need to do better where it comes to adolescents who are missing school, missing sports, missing out on social lives. Stop blaming it on bad periods and give them the diagnosis and early intervention that they need. Racial and ethnic bias plays a huge role. There's this mistaken, outdated old wives' tale that endometriosis is rare among non-white women. And that leads to an incredible diagnostic disparity across different racial and ethnic groups. Unfortunately, Black, Indigenous, and people of color are less likely to be believed diagnosed and treated in an effective manner, in a timely manner. And we know that unfortunately, Black women in particular are more likely to undergo hysterectomy than white peers, but also to experience increased surgical complication rates. And even though the disease location in terms of where the lesion appears in the body, even though it doesn't differ based on race or ethnicity, it does have an impact on the way that the surgery is done. Again, talking about hysterectomy, with Black patients having the highest odds of complications. And we know that Indigenous peoples are less likely to have access to private insurance and specialty care. And even when they could access care, data indicated that they reported the lack of cessation of pain. So we really need to do better as well in the healthcare disparity sector. Gender and sexual diversity. Too many cisnormative blind spots, particularly in the literature. Endometriosis impacts transmasculine and non-binary and other queer people the same way it impacts cis women, yet they are left out of the conversation. There's just a couple case reports here, just by example, to show that we're trying to catch up, but the literature still has an incredibly long way to go. And we know that the LGBT population often feels that they're receiving insensitive care, and it's directly related to their sexual orientation or their gender identity. This is another problem in terms of healthcare disparities. And we need to be having conversations about fertility limiting GYN diseases like endometriosis, yes, but because of the pain and the impact on life, not just because we're concerned about future pregnancies. Fertility is not a concern for many people. So then we'll jump into treatments. I like this quote in particular because I think it sums up, the gist of how treatments should be offered for endometriosis. The physician should be able to look the patient in the eye and explain in detail all the available treatments, not just those which they prefer. Obviously, first, we'll talk about surgery. As I said, it affords confirmation of diagnosis. You also want to have the disease removed. If you're having surgery, it shouldn't just be a diagnostic surgery and you go about your way. You should also have the disease removed in the same surgical encounter. Now, with that said, all surgery for endometriosis is not the same, and all surgeons are not equal. In particular, you want to seek out someone with a high level of training and surgical experience, not just to maximize your outcomes, but importantly, to minimize complication rates. We at our center prefer excision. We feel that excisional biopsy offers the best symptomatic relief and improvement in quality of life. And we know that the data also reflects same, particularly in the case of deep endometriosis and particularly with bowel involvement. And complete excision of the lesion can result in lower rates of recurrence and or persistence in both deeply infiltrating and ovarian disease. Pelvic floor therapy is something which has really become over the years to be an integral component of endometriosis treatment, particularly after surgery. Some folks will do it before surgery as well. Either way is fine. Physical therapy with highly trained pelvic floor therapist who understands the disease can really help alleviate pain and dysfunction both before and after surgery, particularly excision surgery, can really improve quality of life. There's been several case studies around pelvic floor trigger point injections, things like that, which really helped improve endometriosis-related pain, not just physical pain, but also function related to intercourse and sex, ability to work, and sleep quality. So it's a really important care component, which if folks can access it, they should try to. Medical suppression, very popular. I know a couple of years ago, there was a physician on social media who called it surgery in a pill. Medical suppression is not surgery in a pill, that it was an irresponsible statement. I want to point that out. Even the manufacturer does not call it surgery in a pill. Medical suppression can be very helpful for folks, either in absence of surgery, in conjunction with surgery, or if that's their decision. Not one particular therapy is particularly better than any other. All of them operate on the same premise: create a sense of amenorrhea, stop the period. It's supposed to relieve endometriosis-related pain. not actually treat the disease. All drugs have side effects. Patients should be counseled very well on side effects and be able to make an informed decision about which drug they want to take. Some points from the literature regarding poor response. We know that data indicated that numerous patients showed poor response during or after treatment, which sometimes interrupted the treatment. In other words, they came off of it. If you've ever been on a drug therapy for endometriosis, you may have experienced that. And as they said in one study, for a disease that affects so many, it's unfortunate that the only non-surgical option is one that is so unfavorable among patients. But it is an option, and it is the patient's choice. And as long as they're making educated decisions about it, they should be offered the best medication for their situation in accordance with their lifestyle and their needs and what works for them. Adjuncts, really important. It's particularly social and emotional support. And this was validated by systematic reviews. Finding others who understand, organizations like TTEA who are doing the work and putting in the hours to help uplift others, so important. Some folks love exercise, other folks love aromatherapy. I mean, there's any host of, integrative adjuncts that folks can try. And a lot of it is self-directed. So you just need to make sure that you're working with, qualified practitioners and that you have all the information available to you to make educated and informed decisions. Talking a minute about hysterectomy, removal of the ovaries and tubes, and or menopause. It is an old wives' tale that if you don't have a uterus, you can't have endometriosis. We talked about that. Hysterectomy does have a role in pelvic pain and endometriosis. It may not be right for everybody. The bottom line is it is not a cure. Now, with that said, it will cure adenomyosis, which is confined to the uterus. Sometimes folks will have endometriosis and adenomyosis together. For someone like me, post-excision, I continued to have pain of uterine origin. Hysterectomy was right for me. For others, they may want to preserve the uterus. Unfortunately, some of the limited data that we have showed that there's a possibility of pain persisting after hysterectomy as high as 15%, getting worse as high as 5%. Some older studies found new endometriosis for the first time after hysterectomy in a very low percentage. We do know, of course, that failure to remove the disease increases the likelihood of recurrence, particularly around the ovaries if they are preserved. And again, we have to have that conversation. There is a potential, again, very, very low, very rare, but the potential is there for malignant transformation. It is in the literature, it has happened. So when considering hysterectomy, if it's right for you, talk to your doctor, go over your situation, understand the pros and cons, make that educated and fully informed decision. Multidisciplinary teams, okay? The GYN can't just do this by themselves, right? You want to have a multidisciplinary or an interdisciplinary OR in which you've got your endosurgeon who has built a team like Dr. Sonervo has done for our center with the cardiothoracic surgeon and the urology surgeon and the GI surgeon. We've got a whole team in there so that we can address every aspect of the disease in one encounter. But also after surgery, super important to really focus on the biopsychosocial model. You want to really address other things, psychotherapy, not because it's in your head, but because sometimes cognitive behavioral and other types of therapies can really help you cope and help you modulate your pain. Pharmacological, of course, refers to medication. You really want to look for a combination. Multidisciplinary teams may be mental health support, it may be pain management, it may be your PT, it may be your therapist, it may be your nutritionist. All of these parties play a really important role in addressing what is a multifactorial disease that requires multifactorial intervention. Now, that care should be coordinated. Typically, with centers of expertise like ours, we will help our patients find such referrals. But in areas where folks don't have access, turn to the support groups, turn to your peers, turn to people who know the others that are out there that can help you get connected to better care. Timely referrals. so warranted. We know that general practitioners in particular felt very ill at ease in diagnosing and following up with their endometriosis patients. In a second study, 77% of general practitioners felt they needed more education, and only 25% stated that they knew enough about endometriosis for routine clinical practice. And this has some really big implications because there's been a recent conversation, out there in the endo world where they're trying to funnel endometriosis patients to GPs. I just don't see how that's going to work when GPs are not specializing in the disease and they don't even feel comfortable diagnosing or treating it as it is. So there's something to be said for that. 82% of GYNs themselves, which is the discipline that primarily treats endometriosis, indicated they were not able or didn't feel comfortable in performing advanced laparoscopic surgery that's required for endometriosis. We don't have a lot of fellowship trained specialists who focus solely on endometriosis, although that is growing through organizations like the AAGL and the SLS. And there's really a lack of what they call disarticulated care, which can really lead to ignored and undertreated and mistreated disease. So again, we have to close, that single provider model and really focus on doing a multidisciplinary comprehensive care model where everybody is involved in helping the patient feel better. And sometimes that may come from unexpected sources. It may be advocacy groups, it may be legislators, it may be hospitals that are not involved in treating the patient, but treat other patients. So everybody has to get together and be of the one mind that we've got to really promote excellence in timely endometriosis care. And also with the collaboration, there's something to be said about tracking data as well. Having combined outcomes data really helps identify what our best practices and helps improve the standards of care, which are really so lacking. But again, one size does not fit all. This is not to say you will have excision surgery and a little bit of PT and you will feel amazing. Unfortunately, that doesn't happen for everybody. The optimal treatment is multidisciplinary and it's based on what the patient needs, that individual patient. Talking about centralization of care, that really helps empower the patient also because it helps them understand who on their team is responsible for what, and it's focusing on the individual patient and really working together to improve their quality of life. I want to talk a few seconds about the costs of this disease from a societal perspective, an individual perspective, and really the intangibles that we don't talk about enough. Things like impact on body image, our daily lives, our emotional well-being, our family, okay, mostly unpaid caregivers, right, our family. The fatigue levels we suffer from, fertility impacts for those who are concerned with fertility issues, really our overall well-being, our overall existence. But it also costs countries money as well from a financial perspective. When we look at the peer groups affected by endometriosis in contrast to those also affected, or I should say in contrast to those affected by diabetes, Crohn's, and rheumatoid arthritis, which are much more well-recognized diseases, we know that from a public health perspective, the costs are on par. Just to give you some examples, here in this country, almost $70 billion a year in direct and indirect costs. When you compare that to the diabetes burden per patient in the same peer population, it's almost, in some studies, 70% higher. Canada, an estimated $1.8 billion, $30 million of which is related to hospital costs alone. Older data in Australia indicates almost 7 billion. Germany, the data is a little bit dated, but we're talking about 40 million. Same for Italy, around 54 million. So it's a major, major cost burden. And unfortunately, even though it's a major public health crisis and a huge cost burden to countries, it remains underfunded and under-researched. We know that of the 2021 NIH budget, research funding budget, of the $42 billion that was earmarked for for endometriosis, only $16 million for endometriosis, which sounds like a lot when you say $16 million for endometriosis, that's a lot. It's not, it's 0.038%. And if you break it down, it's $2 per patient. When we look at the same peer group again, by contrast, diabetes gets $31 per patient, which is 1,500% more. Work impact. Some folks with endometriosis have become totally incapacitated and had to quit their jobs. Severe economic consequences for the individual, wallet and pocketbook. We know that folks with endometriosis have indicated lower annual salary rates and salary growth, as well as missing things like bonuses, they've lost on clients. Obviously, of course, higher absenteeism rates, particularly as compared to peer groups with headaches, arthritis, and back pain. Decreases in the quality of one's work, limitations in ability to perform work-related activities, and missing anywhere between 19 to 33 days a year overall due to endometriosis, including things like surgery and recovery. And this is a crisis because folks with endometriosis typically do not qualify for disability. Interestingly enough, some of the impacts of endometriosis, some of the symptoms will qualify, but the disease itself does not qualify for disability. And paid leave is very sorely lacking and inequitable. We don't have any, formal FMLA plans in place that will benefit everybody. And unfortunately, the impact of endometriosis, even on career choices and one's ability to work in a chosen or desired profession, occurs also. Same with school. 20 to 40% of adolescents indicated that they miss school, particularly due to pelvic symptoms, as well as comorbidities like anxiety and depression. One of the large study in 2019 indicated that a third of students indicated they missed at least one class in the 3 months prior to the study due to menstrual symptoms, missing things like sports, social activities, which we've talked about. And there were significantly higher levels of lost productivity in the younger patient versus older counterparts, and their symptoms were more severe. Unfortunately, because there's so much stigma around endometriosis, and for those who have menstrual pain as part of their symptom profile, there's such stigma and taboo that they're not talking about it. They didn't want to talk to their teachers. They didn't want to talk to doctors. They didn't want to talk to their parents or their bosses. They didn't want to talk to anybody about it. So unfortunately, days lost of school and work, and 82% had never even heard of endometriosis in another study. So I want to switch gears here a little bit and remind everybody you don't have to suffer in silence or scream to be heard with this disease. You didn't cause this disease. It's not your fault. Nothing you did resulted in endometriosis. You didn't not eat something or eat the wrong thing. You didn't do anything, as a child. This disease is not your fault. Unfortunately, there's no prevention and no absolute cure, but we know treatments can help. Endometriosis is not contagious. Of course, some folks still think that. I don't know why. It's not. It's a very highly common, frequently chronically painful disease. You have about almost 200 million others who understand you. Don't be afraid to use your voice. Stand up, tell your story, tell your truth, advocate for your rights. Understand and tell the others. Periods aren't supposed to keep you bedridden. Pain in general at any time is not normal, whether it's during your period or otherwise. If you or someone is suffering from menstrual-related symptoms relative to endometriosis as part of their symptom profile, and they're not getting relief from over-the-counter remedies or things like Tylenol or a heating pad, and they're experiencing stabbing or burning or ice pick pain, this is not a normal part of life. You don't have to suffer with it. If you're missing school or work or social functions, if you're coughing up blood, if you have bowel or urinary issues, if you have pain with a tampon, if you've got other comorbidities, things like interstitial cystitis or painful bladder syndrome, or IBS or IBD, help is out there. Excision is the surgical approach, but sometimes surgery alone is not enough. We want to look into those adjuncts, things we talked about, multidisciplinary care. And the collaborative experts will take a journey with you. If you're being dismissed at the doctor or you're not being believed, you don't have to keep them as your doctor. If you want to do a free records review with Dr. Eugenio Colon or Dr. Cinervo, stop by centerforendo.com and sign up. We can look at your records for you and offer our opinion and potential treatment. So to summarize the disease on one slide, if we can, no demonstrated prevention or cure, but there is help. Treatments are multidisciplinary. Sometimes you will feel better with this disease. Sometimes you will feel worse. The symptom burden tracks with function levels. In other words, obviously, if you're feeling worse, you're going to function less, but it's not a linear disease. Just as healing from surgery is not linear or healing from treatments are not linear, the disease process is not linear. You may feel great on Tuesday at 2 o'clock, and by 7 o'clock on Tuesday, you have to go to bed. That is the nature of the disease. And unfortunately, some folks around us don't understand that. But there are things we can do. Use your voice, change the narrative. Elucidate the enigma at the bench. Bench refers to the research side. We really need to better improve and fund and disseminate more meaningful substantive research that impacts the people here and now with the disease. And as Dr. Orbuck said in Below the Belt, we need clean money. We need unbiased research that's neutral, that looks at the lesion, not just menstrual effluent or painful periods. Studies that are looking into why the disease occurs, standardizing approaches to treating the disease, understanding the disease biology better, looking into the connections to malignancies and cancer, better diagnostic modalities, hopefully one day a real non-invasive, predictable technology that will enable us to get an early diagnosis and treatment. Once we've got those findings, we need to disseminate them, talk to the primary care settings, talk to the psychologists, the urologists, the nurses, the community health centers. And patients and their families are the ones who are advising to improve the research priorities, design, and experience. Our voices make a difference. And we're doing that. Several of us serve on the Department of Defense CDMRP. We help shape the direction of the research. We help review the grants. We help fund the studies that mean something. At the Beltway refers to the political aspects of the disease. It is patients, again, who are essential in changing and improving policies and getting rid of policies that don't work. And they are the ones that are really driving the public health education campaign. Anytime we improve health literacy of the public and health education of the public, we are better understanding the disease, and those around us are better understanding the disease. We are helping to promote health equity. We've got to continue to confront the bias, racial, gender, and socioeconomic disparities, which diminish care seeking and provide barriers to care. We want to get rid of the stigmas, get rid of the taboos. All of these things impact treatment and diagnosis. We want to ensure equitable access to appropriate and safe care for everybody who is affected by this disease. We're working on the access to care and the cost issues. It's a political disease, but it's not a political disease. Everybody bipartisanly has to be represented in the movement. We have to meet people where they are. We have to involve everybody in pushing this disease forward. And again, as you've heard me say 100 times, it's not a menstrual disease, but endometriosis is a key component of menstrual education. We know from earlier programs that came before us and data, if people know that their symptoms are real and we instruct them on how, when, and where to get help at first signs, that is critical to their bodily knowledge and autonomy, and it empowers them to get earlier and better care. Working on work and school and economic aspects, programs and policies that will benefit people, including things like in our country, the ADA, developing accommodations and policies that help accommodate people physically or literally and metaphorically. And of course, ensuring that we are including endometriosis wherever coverage enhancements of any kind are being talked about. And we're doing that too. Under Shannon Cohn's Below the Belt movie and related initiatives, we have a 5-point national action plan that we presented in Washington, D.C. There are several of us who contributed to this. I am honored to be one person among the others who contributed. And it's really speaking to the public health component, the basic science funding, decreasing barriers, expanding components of effective management and care, and really looking at national action plans not modeled after the existing countries' endometriosis action plans, because they have been met with such resistance and there are too many gaps in them, but really looking at the national action plan on breast cancer, which, you know, talk about standing on shoulders of giants. They have achieved massive things. So we've been doing that. There's some precedent-setting work being issued by Representative Gilchrist in Connecticut, where they are looking to fund a biorepository that will be specifically collecting data and outcomes and studying the lesion itself. So we're working on that too. So we want to unmask the mystery, particularly at the bedside where we are receiving our care. We want to achieve reduction of costs. We want access to early value-based care, and advocates are the ones doing these. You know, unfortunately, it is unethical to deny access to treatments that can have life-changing impact, but physicians and payers are doing it every day. So we're working hard really to, you know, strive for tertiary efforts which are going to reduce the impact, or striving to reduce the impact on the people suffering here and now, people like you and me. You know, we want to increase surgical training, and we want to have, you know, we want to have real stock of the lack of adequacy in existing care so that we can change it. We have to improve the standards. We've got to improve timely intervention and better care. And we've got to make that care accessible to everybody. And again, it's patients and families who are doing it. You know, it's not, if you follow me and you saw my post today, it's not the Park Avenue physician who's doing it. It's the patients that are doing it. And we're doing it. We're working. We're here. We're out there. We're everywhere. We're teaching med students. We're presenting at AGL. We're presenting to doctors. We're doing it. Get involved. If you are thoughtful and informed and engaged, and you can have the modicum of medical knowledge and research experience, and you can review things with a thoughtful, deliberate way, collaborators want you. They want you as an advocate partner. So get involved, join the hospital boards, work with your local support group like the TTEA, find other collaborators, those at the research centers. They want to hear from you. They want advocates. And I want you to be the change you wish to see. Somebody very, very important to me said that to me many years ago. It has always resonated with me. If you are a practitioner watching this, please know that you will learn more from a patient than you will from any textbook ever. If you are a patient, do not be afraid to work with your policymakers on any issue related to endometriosis care, research, and treatment. Again, talk to your hospital administrators, talk to your insurers, talk to your researchers. Influencing public policy is very difficult and complex, but it is requisite. We have to do it. We have to continue to bring endometriosis to the forefront of all public and political discourse. Don't be afraid to use your voice and tell your story. You are the one that is going to influence policy. You are going to improve your community's health. You are going to reduce those disparities. You're going to secure that funding for the research, and you're going to help pass legislation that matters. Because the final stage of healing is using what happens to you to help other people. And that is why I advocate, and that is why I encourage everyone else to advocate, not just for themselves, you know, but certainly be empowered to educate for yourself and get the best care that you can, where you can, how you can, as quickly as you can, but also to advocate as agency. That rising tide lifts all the boats. You know, for me, my time with active endometriosis is past. It's my job now to serve as an ally and make sure that I stand in the gap so that others don't suffer as I had. And that's what folks like Shannon Cohn are doing. You know, like I said, we've got the National Action Plan, you've got the Nurses and Practitioners Education Program. You know that the Below the Belt is making the rounds. If you can see it, I highly and strongly encourage you to do so. You will feel validated. If you have the disease, you will be fired up if you feel like advocating. The Endometriosis Summit, fantastic organization. We will be there at the end of this week coming up to once again gather in the rooms with the researchers, the legislators, the scientists, the physicians, and most importantly, the patients. Little free resource for you. I don't expect anybody to write this down. Get in touch with me. I'll send you the link. This is an academic handbook. There's some really good information about endometriosis, but also in terms of menstrual studies in general, if anybody's interested. And you can jump on our website anytime, centerforendo.com. We do all sorts of resources and advocacy and help for the endometriosis community, in addition to being a leading treatment center. And we are just happy to help you any way that we can. And with that, I will stop my share and we can do whatever Ambah tells me to do, Q&A or whatever she would like.
Thank you so much, Heather, for your presentation. Thank you, thank you, thank you. I must say, you know, while we do not have any questions, Liz has thanked you for your presentation. Thank you, Liz. But I want to start the discussion where I know you spoke about seeing different things happening in the body, especially for those who have endometriosis. So you talk about rheumatoid arthritis, sometimes you're seeing increased migraine, coronary heart disease, but I did not hear cancer. And that is a question a lot of people ask. Does endometriosis lead to cancer? Can it be a determinant factor for you getting cancer?
Well, when we talk about the malignancies, the rate is very, very low. And I'm very cautious with my remarks about that, because immediately someone will think I have endo, that means I have cancer. You don't. You do have a slightly increased risk of malignant transformation and other cancers. So in other words, malignant transformation of the lesion itself or of other cancers. But again, there's an abundance of data on cancer and endometriosis. We know there is a relationship. We don't necessarily know why. Maybe they share underlying causes. But all of the research agrees that the risk is very, very low. I like patients to be aware of it, but I don't want anybody to be terrified of it.
Okay, all right, good. Now, you talked about the multidisciplinary approach, and that is something we have been trying to tell our members as well. It's not only purely academic. We go to the doctor deals with it. Sometimes you need a pelvic floor practitioner, you need a nutritionist, you need someone to help with your exercise. It has to be a whole body approach to help us manage it.
Absolutely. And I recognize there's a lot of privilege in that, in being able to access that kind of care. And I know that it's very difficult, you know, for a lot of people with endometriosis. Treatment means the difference between feeding their family or obtaining their prescription. And I fully recognize that. You know, and that is one of the reasons that we are all so fired up, you know, in the advocacy circle, to really make a difference in that regard, so that everybody can access that care. If you can access it, that is the best way to go, is an interdisciplinary, multidisciplinary approach. And that's really because it is a multidisciplinary disease, a multifactorial disease. It affects so many different parts, you know, of our body from head to toe, really. It's important to come in with all the tools in the armamentarium.
Right. Now, I am having some problems with my video. I do not know why. I am seeing my video.
Is it time for interpretive dance?
I don't know. Probably this is the best time because nobody can see me. No, I see Shauna has put it, and it's one of my notes. Oh, there it is. I do not know what happened there. Hi,
I
Ambah.
see Shauna's note. Thank you, Shauna.
Yes, the research, and what I noted, and I wrote it down, that the research is ongoing as the latest was in 2022. And this for me is phenomenal because it shows that, you know, the practitioners are really trying to get to the bottom of this. And it means that doctors now have more material in which they can review. And that should translate to better treatment for patients.
We hope so. We hope so. That's the
You
goal.
know?
You know, we sometimes
Correct.
it's easy to be discouraged. You know, we say like, oh, 2 steps forward, 5 steps back. And it does, it gets discouraging. You know, there's always going to be the naysayer, there's always going to be a guideline we don't agree with, but we are a really, really strong and empowered and smart community. You know, I said it before, you will learn more from a patient than any book out there. And if folks would just take the time to listen to their patients, they could learn a lot.
Now, you made mention of the doctors that stated that, you know, the percentage that did not have. Oh, I'm sorry about that. Ooh, like I have a frog in my throat now. Sorry. Who's noted that they did not have the expertise. Um, and I wanted our members and those here to realize this is not something that is just specific to Trinidad and Tobago or the Caribbean. This is something that's seen the world over, because we do have problems with some of our doctors here who write us off from this jump, who immediately tell you, well, we have some doctors who tell you, yes, have a hysterectomy, you'll be cured, or you're Black. That's not for you. You know, and it's not specific to Trinidad and Tobago. This is something seen all over the world. And it's just to find the right practitioner who understands the literature, understands the disease, to give you the best options.
Oh, absolutely. And sometimes the best practitioner is the one who says, I don't know.
Correct.
Sometimes that's the best one because they're honest and there's no ego getting in the way. They're going to
Yes.
help you. They're going to connect you to colleagues and better care. I mean, I can tell you over even just the last 5 years, the amount of physician referrals that we receive has really increased exponentially, which shows me that they're more willing now to say, okay, yeah, just like I would send my patient to an oncologist or, you know, cardiologist, I'm going to send them to an endo specialist, somebody who focuses on the disease. I mean, you're still going to get that doctor who drops their patient because they went elsewhere for care, or you're still going to get, I can do that. You know, you're always going to run into that. You know, medicine is an art and a science with human beings behind it. So you're always going to have the fallible, but I do see, you know, much more acceptance, much more willingness to collaborate, which is really, really important in terms of patient outcomes and supporting the patient. I mean, if you're not supporting your patient, you shouldn't be doing medicine at all, period.
Agreed. And as you say, research as well. This is a plug because we have some UE students, medical students, whose topic is actually into endometriosis and the impact on its patients.
I love
And
that.
I was pleasantly surprised and I jumped on it immediately. So this is a plug for those that are here who would have received our email. Please complete the questionnaire. It's research and it's going to help us in the long run. Plug for
No,
UE.
absolutely. No, I will tell you, particularly what they call here the HOSAs, which is a student healthcare group, but also medical students who are, you know, residents and things like that. Whenever I lecture to them, they have the best questions. They're the hungriest for knowledge and they're the most innovative. They're always coming up on the fly with ideas about, well, why don't we try this?
Mm-hmm.
You know, they're the ones that are going to lead the way.
Definitely, definitely. Now, there's a question in the group. Right. So Heather says, I had surgery in CC in 2017, including thoracic. I've been on progestin since and recently a combined pill. Lots of bleeding problems, but my current challenge is bowel/colon pain that's getting progressively worse. And I'm not sure of the next step. At the time of surgery, my uterus was attached to the bowel and it was separated.
You will definitely have to call the office.
You heard that, Jolene? You will have to call them.
Get in touch.
So that they,
We'll help.
yeah, get in touch, yeah. Especially as they have your files there already. Definitely. I want to talk about, now you made mention of the school impact. And I remember just as COVID hit us in Trinidad and we went on lockdown, a colleague of mine, our sons went to school together. When she heard my story about endo, she said, oh, I needed to come and speak to my Form 3s. Those are those in 13 to 14 age bracket, boys and girls. Said challenge accepted, because usually we don't want to talk to the boys. I said no, they have mommy, sisters, girlfriends. Yeah, let's talk to the boys too. And I remember one girl saying at the end of it, so miss, this is what I have. I said, why you think so? She said, miss, I miss school every month. The pain you're talking about, I experience that every month. My mother experiences it every month, and my entire family thinks we are both drama queens and that we are lying about it. The teachers do not want to understand because every month I'm missing school because of a period, and I was in shock, and she said, miss, thank you. Now I know what this could be.
Oh, no.
And that's the thing, because so many of our teenage girls are going through this and do not understand what is going on, and no one is listening. Nobody's listening.
That's the thing. It was interesting to me, speaking with the whole school nurse program. And again, the most interesting class I ever taught was a bunch of 6th graders, boys and girls. And again, they had the best questions of anybody ever. But thinking in terms of the school nurse, I mean, there's so many kids or individuals that will present to the school nurse first. If they do have the courage to talk to anybody about it at all, likely it's going to be the school nurse, or that nurse should have enough wherewithal to say, you're in here again, something's going on. So the school nurse education kit is so critical, and we wrote it into the legislation, and it didn't pass because only two nurses said, we don't encounter endometriosis. Well, I don't know what school you're at. So we had to remove that, not remove it from the bill, but remove it as a required educational component. Right. Otherwise, the bill wouldn't have moved off the floor. But I thought that was super interesting that there are nurses who think they don't encounter endometriosis in their work. And I thought, well, I don't know what school that is.
No, Sharice is asking, is an elevated CA125 test together with ultrasound sufficient to diagnose endo? She says she has a cyst, ovarian adhesions, and adenomyosis.
See, that would be, sort of a complex diagnosis, because is the pain of uterine origin solely, or could endometriosis also be present? Now, with CA125, unfortunately, you'll get a lot of false readings when endometriosis is present. So it could be very elevated, which can cause panic for the patient, but also be inaccurate in terms of a diagnosis. So to isolate it based on a CA125 and then add an ultrasound to it, you can have increased suspicion, and they may want to start, if you are amenable, they would look at maybe thinking about starting clinical care for it, obtain a clinical diagnosis, start clinical treatment, which in that case would be probably medical therapy. If that's something that you were comfortable with and wanted to do, you could definitely do that. At the end of the day, you really need a biopsy confirmation to know that it is 100% endometriosis. But again, that's up to the patient if they want an absolute diagnosis or if they're comfortable with a working suspicion of diagnosis.
Sharice, I hope that answers your question. You can let us know in the chat, or you can give us a thumbs up, or if you have further questions, feel free to type. Now, you spoke about speak up, no need to shout, tell your story. Now,
absolutely.
For years, I never wanted to tell my story because I thought I was weird. Shuri says, thank you for your response, Heather. And I remember while I was in college, we were doing can't remember the name of the course. And we were looking at different diseases, and there on the screen was endometriosis. I said, okay, I'll take it. I'll take it. Yeah, that's me.
I'll do it.
And I did it. And my brothers in the group were like, you have this? Mm-hmm. Well, this is why you are sometimes in the corner in the classroom, not talking to anybody. Mm-hmm. Yeah, that's why. And I still didn't tell anybody the story. I was afraid to tell people in work. I was still coming to work. I will be cranky with everybody. Do not come around me. Do not tell me anything. And it's only as I became more involved with the TTEA. And then our former president is here, Abisha, and Abisha said, Ambah, let's do this. And then I realized that meant me coming out of my comfort zone and doing the uncomfortable thing of talking about it.
Yeah.
And recently we had a feature in the Express, one of our local newspapers. And I sent it to a few guys I went to school with. I said, hey, check it out. Clearly one of them sent it to another guy I went to school with. And his message to me was, you can tell me you had this before. I said, what? And he was like, but I never knew this about it. I said, because I never told my story because I didn't think you guys would understand. And he remembered a time I was rolling in pain in the art classroom on a table. And he could not understand what was going on with me. And I said, yeah, I was going through it then. You know, and I am now realizing men today, well, not all men, some men today are more open about talking about women's health and women's bodies.
I think
which
so
is
too.
A big surprise to me right now.
No, I think so too. I mean, you know, you're always going to have the backwards ones, but I think that there's a lot more openness and conversation that goes on, or at least they're not going, you know.
Yes.
They're more amenable to having that conversation and you know, being open to learning about it. You know, it's a difficult dynamic, particularly if it's an intimate partner and you're you know, and that's true of either gender, male or female partner, what have you. You know, they want to fix you, they want to help you, they want to care for you. It can be very difficult, not as difficult as living with endo, but it can be very difficult. But it's true too with employers, teachers, school professors, etc. You know, nobody wants to go to their boss and be like, oh, listen, I'm out again. But that's because we just had it ingrained in us for so long that this is a stigmatic disease and don't talk about it. And we don't talk about bowel problems. We don't talk about urinary problems. We don't talk about periods or bowel problems that are, you know, caused by, we don't talk about it. Although now, I mean, even just in the last 10 years, I can definitely see a major increase in people speaking out. And you know, that's how bots are formed. Oh, you too? People, you know, they see themselves in you. You're helping people that you don't even know. You know, I get messages all the time, even now, like, thank you. I'm like, no, don't thank me. Thank the, you know, the giants whose shoulders I stand on, because we've got to talk about it. We've got to talk about it.
Correct. I remember too last year when we were on, it was with Dr. Jackman and myself, and unbeknownst to me, one of our board members was watching. Now, it was early in the morning, and I hope nobody from work was watching TV at that time. Everybody's preparing to go to work. And then my director calls, Ambah, were you on TV? Yeah. She said, was it for our organization? No. And then she said, the board members saw you, yada, and they're impressed, whatever. I said, oh. Okay, so you do watch TV at this hour of the morning. Okay.
Now you know.
Cool. You know, okay. Tasha's saying, thank you so much for the host for having the discussion. My question is, can you elaborate a bit on sciatic endo? I have heard about it for the first time this week, and it sounds like that is what she's going through.
Yeah, we have a really good in-depth article at centerforendo.com on sciatic endo. Of course, you know, you'll hear that it's very rare. Again, I am not of the mindset that it's rare in as much as underdiagnosed. and under-recognized. Probably we know a lot more people with it that haven't been diagnosed than they say that there are. But yes, I mean, it can be exacerbated by endometriosis. You can have terrible pain, gluteal leg, back of the knee, hamstring type pain all the way down the leg. When removed, pain relief has been profound for many people. But I would encourage you definitely jump on the website. There's a drop-down tab. I believe it says sciatic endo. There's a whole article there that will give you a whole part and parcel of what it is, how to diagnose it, and how to treat it. And again, that, also that's something that you would require, another specialist in the OR to treat. So again, that speaks to the importance of, that multidisciplinary and interdisciplinary OR.
If you can, thank you, Shauna. I see we have a Jamaican in the house. Thank you, Shauna, for joining us tonight. Could you, Heather,
Shauna? Shauna's gonna be mad I'm not in yellow. I'm sorry, Shauna.
That's okay. I'm glad she was here, though. Hey, Shauna.
I'm not in yellow either.
Okay, I'm good.
But I've got yellow nails.
All right, that was something.
Great conversation. Love that we're having it. I have to run, but really enjoyed it. Excellent research cited, and we'll be in touch.
Thank you very much, Shauna. We shall.
Bye, Shauna.
Bye. Heather, can you put in the chat the website for persons like Tasha so she can check the article? We can all check that article. Yes. So I don't see any more questions. And I think that's all the notes that I jotted down on my piece of paper this side here. But right, so there it is, centerforendo.com, and we can go there for some great articles. Do you mind if, let me ask, but Heather, I'll ask you that after. Because I see that you do have articles there, so I'll speak to you on it after. But I want us to be able to go there, and I want our members to remember that, yes, UB students are doing a research on endometriosis and how it affects our lives. And I think, as Heather rightly said, they can learn about endo in a chapter in a big medical book. They will have multiple chapters on cancer, multiple chapters on endo. They may get, if they get a chapter on endo, they're lucky. Some may just get a paragraph.
They're really thin, like little thin chapters. Sometimes one little thin chapter.
Correct. And these students have recognized the importance of doing research in endo. And as Heather rightly said, the only way you can learn about it is speaking to the persons that have it.
Absolutely. That's why we've got to be
hear
everywhere.
Our voice. I'm asking you to please,
wherever decisions are being made.
Correct.
That's right.
Correct. These are our future doctors. They may be the ones that change the ball game for the Caribbean. You may never know.
Well, the ones out there now aren't doing it. So let's hope.
Correct. So Heather, on behalf of the TTEA and our members, I want to thank you for gracing us, the crazy lady with her spunk this evening. You brought a lot of research, but it did not feel academic.
Good.
You broke it down for us, and for that, I really appreciate you for this, Heather. It's much love from us in Trinidad and Tobago for you and you guys and Dr. Sanovo. So we want to thank you again to the members who once again stuck with us for year 3 and have attended. We want to thank you for joining us this evening. Because of you, we do what we do. And without you, we will have no Spotlight Endometriosis. So thank you for the continued support, and look out for more information for better and greater things coming up as the year progresses. Yep. And I wish you a good evening. Yes. And thanks again.
Thank you for all that you do. Keep up the good work. Tell everybody there hello and much love from me. Much love to Abisha. Give her a hug from me and give yourself one, and keep doing what you do because it's invaluable.
Thank you very much. I think Abisha is here with us.
She? Oh, good.
Yes,
okay.
I think Abisha is here. She logged on. I don't know. She probably dropped off, but she was here earlier, so she was here. So
she knows
thanks
all
again.
of us anyway, so that's fine.
Correct.
She's the expert.
She is.
She is. She is, as are you all. All right. Thank you again.
Much.
I really appreciate everybody who came out, spent Saturday night with the friendos. We appreciate it. And much love to you all. And we will see you soon.
We will. Good night, everyone. And thanks again.